Thank you very much for joining our latest media briefing on important healthcare issues in the news. I'm Dr. Rose Zacharias, president at the Ontario Medical Association, which represents more than 43,000 physicians in Ontario. Today, we're going to explore the toll that COVID-19 has taken, not just on our physical health, but on our mental health and our society. The pandemic disrupted the global economy, widened all sorts of inequalities, interrupted our children's education, and forever changed how we work, play, live, and interact with one another. We know the pandemic worsened burnout for healthcare workers and others on the front lines. And more people are suffering from mental health issues such as substance use, depression, and did the pandemic also make us more lonely and less kind? We have a panel of experts here today to discuss these issues and to answer your questions. So thank you so much for coming with your questions. We will talk about a new study that shows an increase in racism, body shaming, and other harmful behavior among youth during the pandemic. Increased screen time and decreased empathy may be factors at play there as well. Mental health and addictions experts are saying substance use rose during the pandemic and continues to rise. Wait times for community mental health services have tripled. Patients are reporting increased stress from economic and affordability issues, including food prices. Physicians, meanwhile, are working to keep up with the demand while facing record levels of burnout. Physician wellness has been a special focus of mine during my tenure as president of the OMA, and thank you for being here and highlighting this issue as well as all of the other issues that we're mentioning here today. When the OMA did its annual survey of members in 2022, 93% of physicians agreed that doctors are feeling burnt out, and 66% of respondents strongly agreed with that statement. Women, mid-career physicians, and general practitioners appear to be the most strongly impacted there. The main thing contributing to burnout is the lack of healthcare system resources to provide timely care, as well as the increasing complexity of patients. We know that the administrative burden on physicians also contributes to burnout. Physicians spend an average of 10.5 hours a week filling out forms and handling other administrative tasks. That's the equivalent of a long additional day of work for those physicians. The OMA's Physician Health Program saw a 20% increase in calls in 2021 compared to that before the pandemic. Approximately 1/4 of these calls were related to stress and to burnout. These figures likely underestimate the problem, as not all physicians experiencing burnout will reach out for assistance to the Physician Health Program. So with all of that, I would like to now introduce to you today's panel of experts. Dr. Caitlin Mendez is an associate professor and Canada Research Chair in Inequality and Gender at the University of Western Ontario, who explores how digital technologies pave the way for new forms of online abuse. Welcome, Dr. Mendez. It's really good to have you here. Dr. Lisa Lefebvre is Associate Medical Director of the Ontario Medical Association's Physician Health Program and a Community Addiction Medicine Physician at True North Medical in Toronto. Welcome, Dr. Lefebvre. And Dr. John Novick is the Medical Director of the OMA's Physician Health Program in Toronto. He is a psychiatrist, psychoanalyst, and addiction medicine specialist who runs a private practice in Oakville as well. Thank you so much, Dr. Novick, for joining us. We are going to start with Dr. Mendez, who will talk about how young people in particular are experiencing isolation and loneliness as a result of the pandemic. It found that as youth spent more time on the internet, there were increased incidents of degrading messages, body shaming, online sexual violence, and other harmful behaviors. Such an important issue to highlight and understand better. So thank you, Dr. Mendez, for being here, and I'd invite you to speak now.
Okay, great. Thank you so much for having me. Okay, so I want to share some findings from research that I recently conducted in the UK with nearly 800 youths aged 13 to 18, teachers and parents. So along with my team, we conducted surveys, focus groups, and interviews immediately after lockdown measures were lifted in 2021, and just as young people were returning to school in person. So we found that lockdown created a significant toll for all three of these groups, but particularly young people. So they told us about things like increased anxiety, the depression, and even various forms of self-harm. And a lot of them noted how these harms were directly linked to their use of digital technologies and screens that increased during COVID. So our research is just one of many studies that show how screen time went up exponentially during COVID. And we had 96% of our survey participants report that their screen time increased during this period. And this has had many negative impacts on young people. So as Dr. Zacharias mentioned, young people told us about things like increase in their experiences of sexual harassment, misogyny, racism, homophobia, and even various forms of fraud like catfishing and other practices like body shaming. And one of the things we found is that teachers really noted this, and they noted that as young people were coming back into school, the way that young people were communicating with each other during lockdowns had changed, and they found that their empathy had really decreased. And this is likely due to things like the lack of eye contact, facial expression, human touch, and even voice intonations. These are really important cues that are missing from online interaction, and this makes empathizing hard. But it means that harassment and abusive comments actually become much easier. So we know digital technology became such an integral part of young people's lives through COVID. But I'd argue that as a society, we haven't yet really thought through how to prepare young people for their digital futures or support them as they experience new and constantly changing challenges. And one of the things we found is that many parents and teachers either weren't aware of some of these new challenges, or they didn't even understand what was really happening. They didn't know how to support young people. So in some ways, young people have really been guinea pigs with all this tech. And I think we still don't know the full implications of this. It's starting to unfold and we're starting to really document it. So the final thing that I'll say is that parents and teachers are really struggling to support young people in this post-COVID environment. And, many teachers and parents, for example, are dealing with their own issues. But again, many simply don't understand the technology, the risks or the harms that it brings. And I would argue that this is something that really needs to be on everyone's radar. Thank you.
Thank you so much, Dr. Mendez. Appreciate your insight there, your study, your commitment to bringing forward the data, especially when it comes to the health of our young people. Thank you so much also to Dr. Lisa Lefebvre for joining us. Wanting to ask you specifically, Dr. Lefebvre, what are patients telling you about substance use during the pandemic and how the economy and rising food prices are affecting their mental health? Thank you, Dr. Lefebvre.
Thank you, Dr. Zacharias. Such a timely question as we transition from sort of a different set of stressors to, unfortunately, a new set for our patients who are struggling with mental health and addiction problems. And I couldn't help but note, Dr. Mendez's mention of isolation. We saw a great increase in substance use, particularly alcohol, and an ongoing increase in opioid use that had already been well described prior to the pandemic, continuing on through the periods of lockdown, not just because of the decreased social contact with peers and family, but also decreased access to many services, although some did transition to online, and particularly well positioned were some of the mental health services. But now I think just the accumulation of a backlog of care, as well as the new stressors related to food insecurity, rising cost of housing, I've really noticed a strain on a lot of my patients who are struggling with the basic necessities of life at this point. And as they try to access services in the community, we have wait times that were previously lengthy that have tripled and sometimes quadrupled at this point in time. And particularly, I've noted in some of the areas where my patients are located, which are not just in Toronto, but outside in other rural and remote areas of the province, often their only place that they can access crisis care at the moment is in the emergency department. And we do know, of course, how strained our emergency departments are with all kinds of health problems that are presenting there. And Dr. Zacharias has mentioned the burnout of staff. Our physicians and our allied health, and particularly our nursing colleagues, have really worked hard through the pandemic, and this increased demand is really a challenge to meet the needs of those patients in a setting that's likely not the most ideal to providing the type of care that they require. So I'm seeing a lot of different types of distress, but ongoing, as it has heightened through the pandemic into the post-pandemic period.
Thank you so much, Dr. Lefebvre. Appreciate those insights, absolutely. And now I'd like to turn things over to Dr. Novick. Thank you also for joining us, Dr. Novick, and just really a very straightforward from your lived experience and clinical perspective. Has the pandemic made burnout worse amongst our physician colleagues? If you could speak to that. Thank you so much.
Thanks so much, Dr. Zacharias. So the obvious answer to that question is yes. I mean, I've said before that being a physician doesn't confer any immunity to any of the things that trouble everybody as humans. And certainly when it comes to burnout, physicians, like many other healthcare workers, the situation has been made a lot worse because of the pandemic. You've already mentioned some of the numbers, but I think it's important to look not just at the prevalence, but several other aspects of burnout, including the impact that it has on physicians professionally and personally, and also to talk about a lot of the solutions that people have been bringing forth, particularly now that the awareness of burnout has, also increased as the numbers have increased. You mentioned burnout numbers earlier. I think it's important to emphasize that the OMA Burnout Task Force measured burnout before the pandemic, and it was already elevated at 66%. And after the pandemic, as if it's actually ended, but a year later, still mid-pandemic, the rate had increased to 75%. So almost 3/4 of physician-reported, meaningful degrees of burnout. Those numbers have been repeated by the surveys done by the Canadian Medical Association as well. And when it comes to impact, I think there's some other numbers that are helpful in illustrating just how significant it's been. There are researchers from Ottawa who've looked at certain types of healthcare visits by physicians and comparing pre-pandemic to mid-pandemic, and were able to demonstrate that the crude numbers per 1,000 physicians went up by 27%. So, burnout affects healthcare workers professionally as well as personally. And if I can share one typical scenario that we might hear at the physician health program, we've had physicians calling up literally in tears because they're so burnt out. They need a break, but they don't know what to do because they're too concerned about their patients not receiving care if they were to take time off, or to burden their peers by asking for coverage. And they really feel quite paralyzed and don't really have a lot of supports to be able to take care of themselves while they're taking care of everybody else.
Thank you, Dr. Novick, for painting a very accurate and difficult to hear visual of the reality of our physician colleagues who are struggling with burnout. And we know those numbers are too high. And I appreciate shedding a spotlight. We so need to address and bring forward solutions around burnout, and the Ontario Medical Association is committed to that. I know that we'll probably get into some of those specifics as we move on now with the question and answer. Thank you to all of our panelists for bringing forward your clinical expertise, your academic expertise, and now we will transition to the question and answer period. I know our room is full. We want to give everybody some time. Already there's questions populating the chat, and continue to do that, putting those questions in the chat. Emily English from the Ontario Medical Association will be moderating this portion of the briefing. If we don't get to your questions, the media team will definitely follow up with you afterwards. You can also email media@oma.org, and we'll put that in the chat for requests for interviews or more information. And we will have a recording of this session available later today. So over to you, Emily. Thank you.
Thank you. Our first question is for Dr. Lefebvre. I wanted to ask about wait times for community mental health services. How you mentioned the backlog of care. How long are wait times now compared to before the pandemic?
Obviously, it's variable and it varies region to region, but I would say in the past, I would see some of my patients waiting for community mental health services, perhaps 3 to 6 months, sort of on an average timeline. And now it's extending 9, sometimes even in certain locations, up to a couple of years wait time to get a therapist. So it's really extended. I said before, tripled to quadrupled. It seems to be a fairly reliable rule of thumb, but significantly longer than before.
And a follow-up question to that, what are you seeing for those who can't access care in a timely way? What is happening?
So I find that some patients are just giving up and not seeking help, or they're coming to their other healthcare providers. You may see them going to their family physician, certainly, but that part of the system we know is also overburdened. So there's a lot of others, I think, trying to step in and fill the gap, who may not necessarily also have the capacity or the training to provide the care. I have some patients who come to see me for conditions that perhaps are not right within my scope, but we try to do our best to fill those gaps. We also are seeing patients, when the symptoms become severe, presenting to the emergency department. I just had a situation like this in my clinic this week, where I had a patient in crisis go to the emergency department, and that really isn't the place for someone. In this case, it was someone with a trauma background to be receiving the care that they need, which is really long-term and very specific and focused.
Thank you. And we have a question from Julie Bertram, who's with the Tribune. Dr. Novick, I'll direct this one to you as it touches on physician burnout. So how has COVID and this ensuing rising cost of living crisis affected physicians' job satisfaction? How many healthcare workers are leaving their positions for new careers? And if it is a high number, what's the impact on the healthcare system?
So let me work back from that. The impact is great. I don't have specific numbers regarding the physicians or the other healthcare providers who are leaving the practice of medicine or healthcare, but we all hear stories of people either changing careers or choosing to retire early. There's a lot of effort that is in place to recruit and retain more healthcare workers. One of the numbers that I have, which is only sort of let's say a proxy for our system, but that has been pretty well supported in the literature in the United States, for example, is that for every physician who leaves a practice, it costs about $1 million to replace them. And if you can't extrapolate or correlate that one-to-one from the United States, but it certainly has an impact not just on healthcare, but healthcare costs. All of these people leaving their work, and I think there was a first part to that question that I don't know if I answered, but
the first part was about job satisfaction. What are you noticing?
Well, there's this balance. So, there are the drivers that contribute to either burnout or joy in medicine. And what we have is this imbalance right now. So if we are able to more consistently and let's say broadly address those drivers, we can rebalance that so that physicians and other healthcare workers are satisfied and engaged with their work as opposed to feeling exhausted, burnt out, and cynical.
And we have a question now for Caitlin Mendez. We want to hear more about your study. You mentioned that there's been a spillover effect. You're seeing more online harms and it's spilling over into real life. As a sociologist, do you see that as a trend that will continue in this post-COVID world?
Yeah, definitely. I think the trend is still very much there. And I think partly it's because what we're actually seeing is, people are adopting digital technologies from younger and younger ages. And so I think that rather than seeing any kind of slowdown post-COVID, it's become the norm. And in fact, digital technologies, for example, are now embedded in so many parts of our life. Whether it's school, schools were forced to go online, use digital technologies, and now that they're back in person, they're still adopting many digital technologies. But I think part of it is maybe people's kind of comfort levels with the technology, or parents. So that was one thing that really came out, is whereas before the pandemic, a lot of parents told us that they had very strict rules and kind of boundaries around digital technology and social media use, those really eroded during the pandemic. And I don't think that we're seeing the same levels. So yeah, I think that it's not going to get better anytime soon, especially as younger and younger children are using digital technologies, and before we really know kind of the full implications of this. So it's something that, I anticipate we're going to keep seeing more harms.
And a follow-up question to that, are there any schools of thought of what could be done to sort of address this issue?
There are lots of things in different countries, like the UK, for example, like there's legislative changes. So an online safety bill. Canada's also been debating doing that. But there's also an education piece. Certainly, I think that's a really, really important part that's currently missing. So things around digital literacy, media literacy, information literacy. I think that these are things that really need to become much more fundamental parts of education as we go forward. And that's a real challenge, because what we're also seeing is, young people are struggling with English, with literacy. And so schools are really putting their emphasis on making sure kids get caught up with those skills, but they're not spending as much time. They don't have the capacity to spend as much time focusing on these other skills that I think are increasingly important.
Thank you. And we have a few more questions from the media. This one's from reporter Donna Wells, and Dr. Lefebvre, I'll address it to you. How do we increase community mental health services? Is it solely a funding issue, or is it also a lack of providers?
Thank you for such a relevant question. I think it's a function of both at the moment. I think we've acknowledged in the past that the mental health system has always struggled from a relative lack of funding, and the issues with respect to healthcare workers leaving their various professions or taking leaves due to burnout certainly exacerbate the capacity of that system. So I think it's a two-pronged solution in terms of increasing the supports available, but also ensuring that the folks who are providing these supports, who are people, they are providing more often than not a direct therapy, whether in a group setting or an individual setting, So this is health human services people time, and investing in the longevity of these healthcare workers' careers, their own well-being, and increasing, if we can, the amount of funding available to increase the supports available. I think it's just one of those positive cycles, rather than being sort of a catch-22 in a negative way, that we overburden people, then they burn out, then they leave, then we decrease the capacity of the system. If we can shore up the system to ensure that we're providing those services, and also providing a healthy work environment for the therapists who are providing these services, so that they stay and that we engage them and we retain them in our health human services workforce is critical.
Thank you very much. And Dr. Zacharias, I'll ask you, if we're talking about health human resources, and we've talked a lot today about physician burnout, could you speak to some of the solutions for physician burnout that the OMA is exploring?
So first of all, we know we have a health human resource crisis. We speak specifically about the doctor shortage. We know that every member of the healthcare team extremely valuable. We know the stressors that our nurses have experienced. I've worked in an emergency department for 20 years, and I know that our teams have been strained with lack of those professionals being available for the shifts. And yet we have a deep conviction and moral conviction to care for patients. In the emergency department, people don't get turned away, and the complexity of issues that show up in the emergency department is considerable often. And so, yes, our health human resource crisis is real. We talk about immediate solutions. We know specifically around physician shortage. We have many internationally trained physicians in Ontario that could be expedited in their licensing. And so we have been very proactive here, working with our college regulator, speaking with the government, and talking about bringing those physicians into the system, reducing the barriers that have been just historically there as far as provision of documentation and examinations. And of course, there's a standard of care that physicians need to acquire before they are able to set up practice in Ontario. And yet we need to reduce barriers that are in place and could be alleviated to bring physicians. We know that hundreds of physicians fit this description, and we could have a more robust doctor we could address the doctor shortage significantly if we applied this immediate solution. Long-term, more medical schools, more residency training positions. And yet we know that training a doctor takes time, 7 to 8 to 10 years. And we need physicians to be educators and teachers when it comes to training physicians. And so we need to increase the capacity of our current physician workforce to have protected time to even dedicate their skills and attention to bringing junior physicians into the healthcare system. So the immediate and the long-term solutions need to be applied to address this human health resource crisis. We have some very specific solutions and are committed to seeing them through, so that over this next while we would feel some of the solutions. Emily, I don't know if there was a second part to the question after the HHR crisis.
I think more just about solutions that the OMA has to relieve some of the administrative burden that physicians are facing.
Yes, so working with our ministry officials, knowing that the administrative burden is the #1 contributor to physician burnout. Doctors spend so much time at their computers, at their desks, looking into a screen, as opposed to patient-facing, building that rapport, developing that relationship, listening, speaking, hearing, developing a therapeutic plan with a patient. We want doctors to be doctors, and the administrative burden over time that has come and been introduced with our electronic medical records is onerous. And so we want to have a bilateral forms committee. We have a bilateral burnout task force committee, and there we are making some concrete gains, decreasing the number of forms, looking to streamline our computer and technology so that software programs are in communication with one another, and taking away, reducing the time for the redundancy of all the computer keyboard clicking that doctors do, and take them away from their patient work. This would restore our joy in medicine. We know it.
Thank you very much. And we have a question from Fakia Beg with the Canadian Press. Caitlin Mendez from the University of Western Ontario. I'll direct this to you. Can you touch a little bit more on how the pandemic also made Canadians meaner? And can you give some specific examples?
Okay. Well, I have lots of anecdotal evidence from the Canadian context, and I have funding. I'm about to go and start field work probably in the next month or two, talking with Canadians about their experiences there. So, the data that I have is from the UK, but I certainly know lots of teachers. My partner is a teacher. So I have lots of anecdotes from teachers talking about, the way that students communicate with each other, with teachers, has really risen. So whether it's experiences of like students sexually harassing female teachers, I have a principal who lives across the street from me who recently had a teacher completely resign, maybe about a month ago, because his grade 2 students were bullying him. But we also hear more broadly, there's been lots of news stories within Canada of swarmings, right? So young people who are committing violent crimes that don't know each other, that are meeting online. I'm sure that there's other colleagues here on this panel who know more about the mental health implications and the ways that young people are increasingly experiencing anxiety, depression. So I do have colleagues at Western who specialize in mental health, and they also tell me anecdotally that, they definitely see these issues are very, very serious. So without wanting to kind of take my data and just extrapolate it to the Canadian context, I don't think it's unique to the UK. I don't think it's unique to Canada. I think it really is quite more of a global phenomenon. And I am anticipating finding similar results here in Canada.
And another question for you, Caitlin. This one comes from Maria Rosales Gerpe. She's with the Cambridge Times. Which populations are most impacted by harassment online?
It really depends on the kind of harassment. So for example, if it's about gender harassment, so there are differences between girls, boys, non-binary, trans people. So trans young people in our research were the most impacted by derogatory or offensive comments about their gender, but followed closely by girls. Boys probably experienced the least for that. For things like body shaming, again, it tends to be girls, people who are non-binary or trans, but boys for that one actually reported the greatest increase in body shaming comments. So I would say the data really differs depending on the kind of harm, but definitely we're seeing girls, non-binary, and trans people. We were also looking at harms based on sexuality. So we had lots of young people report how they were outed during COVID. And so, that's something that, is much more likely to only happen if you're a queer young person. So I can definitely follow up if she's interested in providing more concrete statistics there, but we definitely see differences based on gender and sexuality.
And another question from the Cambridge Times. This one's for Dr. Lefebvre. What are the most prevalent types of drugs leading addictions in Ontario, and is it fentanyl?
That's a great question. With respect to opioids, it most definitely is fentanyl. And that is something that was a sort of change in pattern that was occurring pre-pandemic. And the rates, if you look year to year at the Canadian data with respect to apparent opioid-related poisoning deaths, they've been increasing since pre-pandemic, but that trend has not abated in the least through the pandemic. But we've also seen increased rates, particularly of alcohol. There's research done during the pandemic period with respect to binge drinking. And that is the most commonly misused substance across the whole population. But the opioid crisis in terms of lethality is certainly continues unabated and is really affecting the quality of life and the longevity of life of my patients and our population.
Thank you. And another question from reporter Donna Wells. This one, I'll ask both Dr. Lefebvre and Dr. Mendez to weigh in. Dr. Mendez, I'll start with you. Would you agree that we need education in schools on empathy, media use, and the effects of drugs and drug addiction?
100%. And I think one thing that I'd also like to say is we can't just rely on schools doing it. These are messages and these are lessons that also need to be reinforced at home through parents. And one thing I would really recommend is for parents to really try to get a better understanding of some of the technology that their young people are using, having conversations with their young people. I mean, one of the metaphors I often use is you wouldn't just hand over the keys to a car without ensuring that, you know, the person you're giving the keys is equipped to drive it, knows the rules of the road, knows what to do if something goes wrong. And I think we need to take the same approach when it comes to technology. There needs to be a lot more preparation and education and support and scaffolding that goes into young people's use of digital technologies. And one thing I didn't mention is that it's very clear that when things go wrong, young people do not know where to turn to for help. And that was one of the most striking things that came out of our research. We asked them, you know, for all the different scenarios, what do you do? And most of the time, young people try to deal with it on their own. And I think this is actually one of the causes of many of the other harms that we see, like anxiety, like depression, like self-harm, like school refusing, is because they don't have the skills, the capabilities, the literacy to be able to deal with the issues that are emerging.
Thank you. And Dr. Lefebvre, same question to you. Do you think that things like empathy, media use, and specifically drugs and drug addiction need to be taught in schools?
Absolutely. And, you know, we do currently have a curriculum that does address education around drug and alcohol use. And obviously, I would always advocate for it to continue and to be as robust as it can be. That said, I don't think education is going to prevent 100% of our addiction problems that we see. Substance use disorders are multifactorial: mental health, genetics, psychosocial disadvantage, and all kinds of other aspects play into any given individual's risk of having a problem with drugs or alcohol. And so it's important that we continue a multi-pronged approach to trying to reduce those risk factors across the population. But yes, would support education, absolutely.
Thank you very much. And we have a question now from Marjo John. She's with the Medical Post. I'll ask any of the doctors if they want to weigh in on this. Do you see patients being meaner as well?
I'll jump in to start the answer. I know my colleagues in the room would have something to add. I think what we know is that the complexity of medical issues amongst our patients is higher. There has been a backlog of care while we were dealing with the crisis of COVID. People are waiting longer to be seen, to have their surgeries, for example, hip replacements and knee replacements. People are dealing with chronic pain when that could be alleviated by a procedure or surgery that they're waiting for. That's really nobody's fault. We were dealing with an emergency. Now we need to catch up on that backlog of care. And so we're seeing patients present further along in their suffering, really, which can definitely tax someone's own mental capacity to cope. And there is a discoordinated healthcare system that they're coming into. We also know well over 1 million people in Ontario don't have a family doctor to come alongside them and help navigate the healthcare resources. Many people present to their family doctors for the mental health care that they're needing, and also in crisis coming to the emergency department. And we've already spoken today about how those environments and those healthcare professionals need to be better supported to provide the care that the patients are asking for and needing and deserve. And at the same time, we are very clear as a healthcare profession that workplace harassment would not be tolerated. And so we would definitely stand united there. And I think that has been required. That particular hard line against harassment has been required over this last while, and yet we continue to care for our patients.
Thank you. And Dr. Lefebvre, could you tell us more about how economic factors are now affecting mental health?
I've seen in my practice a variety of different impacts. The most sort of basic is access to food and housing. And I have some patients who are newly homeless. I have patients who are losing significant amounts of weight because they literally aren't able to eat. And it's heartbreaking. I can actually see it in their faces. So that is a huge challenge. But I think also the uncertainty of the job market and supply chain problems. Everyone has a bit more of a sense that things aren't quite as stable as they were, and aren't quite sure what the sort of next shoe that's going to drop around the next corner is, and that breeds a general sense of anxiety. So in not being an economic expert, but just observing these impacts in my patients, I have definitely noted them, and patients will speak explicitly of their challenges in that regard.
And a question that sort of builds off that. This one's from Patty Winza, who's a reporter with the Toronto Star. How much do loneliness and stress play into addictions?
I think, as I mentioned previously, in terms of the multifactorial nature of substance use disorders, having additional stressors reduces your capacity. We often sort of refer to this concept of recovery capital in the addiction world, which is all the different positive things in your life that contribute to you being well and functional. And when we have additional stressors, it reduces our ability to sort of respond to them. And loneliness, humans are social creatures. We thrive on connection. Patients certainly do better when they feel supported by others. And the isolation in the certain parts of the pandemic cannot be understated. Many of my colleagues here today have spoken about that, and sort of coming back to that connection, I think, is important. And we're still not fully there yet. We're still in that transition period from not being connected and figuring out new ways to connect in this sort of new world. And everyone, I think, is still feeling their way through that. I've seen positive aspects of people being out in the world again and engaging in different social and leisure and work activities. So that is good, but it's an ongoing process.
Thank you very much. And I have a question for Dr. Rose Zacharias. The OMA has the prescription for Ontario, and one of the pillars is mental health. Can you talk to us about solutions to address, the mental health issues that we have in society now?
We know that we need more team-based, community-embedded care. And we need to reduce the navigating barriers for people who are wanting to access mental health supports. And so we know that many patients go first to their primary care provider and seek mental health and addictions support. And yet many of our family doctors are not part of teams with psychotherapists, social workers, addiction specialists, or have a real ready network of community supports for that individual patient that is seeking care. And so the coordination needs to be improved in the community of the help that already exists. And we need to improve the amount of resources for people who are seeking mental health support. And we know that when we can alleviate even the administrative burden of doctors, they can spend more time with their patients. I think that also speaks to how we can improve, because it takes quality time to care for a patient with a complex issue. And so we want to alleviate physicians and all the healthcare team providers of other non-patient caring type responsibilities in order to directly invest in their patients. And so all of these solutions exist as specific recommendations inside of our prescription for Ontario, and we're committed to seeing them through.
And another question for Dr. Novick, can you speak to physicians retiring and how that could have a domino effect on overall levels of physician burnout?
Well, if the retiring physician isn't replaced, it means that a patient's either go without a new, whether it's a family doctor or a specialist, or other people in an already overstretched system have to take on that care. It would be helpful to have comparative numbers. The other thing is that, this is more anecdotal, but older physicians, near retiring physicians, also have different kinds of practices than physicians who are newly coming into the system. So it may not actually be a one-for-one kind of equation. And you just have to imagine, let's say a remote community somewhere, whether a physician leaves because of retirement or career change or burnout or something else, there really is this incredible sort of downstream effect, especially in such sort of resource impoverished areas.
Thank you very much. And another question for Caitlin Mendez. You mentioned the study that you have already conducted in the UK. You're looking and you've received funding to replicate it in Canada. Do you expect or hypothesize that there may be different results between the two countries?
Yeah, and especially because in Canada, we're really looking across the nation. We're also we're going into the territories as well. We're specifically going to be looking at the experiences of Indigenous people, rural people, LGBTQ+. So we do anticipate, actually, I think that's really interesting, Dr. Novick, what you were talking about, more remote communities. I think that it's possible that some of the findings may be different. Again, we're going to be going to Yukon sometime over the summer. So I think that the experiences of technology, and we have to remember in Canada, not everyone has really stable broadband. There may be some areas where community relationships are strengthened or kind of weakened. So yeah, I don't think we'll find exactly the same things, but I am anticipating finding a lot of challenges with digital technologies. So anxiety, I think that's actually really interesting. Addiction, young people also told us about the way they feel addicted to their devices and how this also leads to them feeling lonely. It creates all sorts of other social anxieties as well. So I think some of those things will probably be similar, but I'm sure there will be some surprises as well.
Thank you very much. And thank you to everybody who participated today. And thank you to journalists who asked questions. I'm going to turn it over to OME President, Dr. Rose Zacharias, who will end us off with some closing remarks.
Thank you so much, Emily, for moderating, and thank you to all of our panelists. So important to bring this clinical perspective, your academic perspective, of course, gathering the data and the evidence to know better the scope of the issue and to better understand how the pandemic has affected us as a society. We know, and in our prescription for Ontario, we talk about a public health preparedness plan, and we need to leverage all of the learnings that were forced upon us during the pandemic in order to equip and strengthen our healthcare system in order to be prepared for the next unforeseen public health emergency that we will experience. And I do believe that all what our panelists brought to the room today, also how you will report it, will contribute to that knowledge. And so thank you everyone for coming, for your time. Also, on a personal note, this is my last monthly media briefing as the one-year term of president for me comes to an end the 1st of May. Dr. Andrew Park will be coming in as the new president at the Ontario Medical Association. Very excited for that transition for him. And I want to say thank you. These media briefings have been so important. We do believe that as we are positioned as physician leaders on the front lines of healthcare system solution generating, we can contribute to a better healthcare system that has been so strained as a result of the pandemic and has fallen short in several areas even prior to the strain of the pandemic. So thank you. Thank you for the obligation that I know you feel and the conviction to bring forward truth in even a culture of misinformation. It is so important to go out from here. So thank you to the journalists, to the reporters, and the work that you do. And we'd warmly welcome you back in May at our next media briefing. But thank you very much. Any requests for interviews can come through to media@oma.org, and we will go from there. Take care and bye for now.